So this is a communication, recall communication I'm discussing again. That is come also in India 2022 September day 1. That is oculogyric crisis with breakthrough seizure. So the task was in this that this is a girl. She's a teenager girl. She has taken morning metoclopramide and she developed oculogyric crisis. She is a known case of epilepsy patient, but the problem is 2 years she is free. She now want to take the driving license. Now what's about it is oculogyric crisis. She can take the driving license or not. This type agenda was. So I'm discussing as usual IRCAP, introducing myself, making report, taking the consent, telling the agenda, then any attendance and the prior knowledge. So first we tell what is oculogyric crisis. Oculogyric crisis, it is an acute tonic elevation of the both eyes upward and it's involuntary. So it is a acute dystonic reactions and prolonged involuntary of deviation of the eye bilaterally increase up. So sudden reaction occur of the eye, that is bilateral increase of the eye is uproll. Okay. So some risk factor that causing oculogyric crisis. What are the causes? Number one, most cases drugs induce. Example, metoclopramide. It is an antiemetic drug. Then chloroquine. It is antimalarial. Haloperidol. There is tics, tourette, and chorea we use. Olanzapine. That is antipsychogenic. Schizophrenia and bipolar disorder we use. Carbamazepine. That is ETC, anticonvulsant. Antipiperazole it for using tics. So neuroepileptic drugs or high potency of neuroepileptic. Also risk factor for young male. So there are lots of then metabolic like hypocalcemia, hyperthyroidism, hyperparathyroidism, cocaine use, family history of dystonia, and abrupt discontinuation of anticholinergic medications. So we know that first what is oculogyric crisis. Now we know the risk factor, that is some drugs. These are emetic drug like metoclopramide, antipsychotic drug, haloperidol, then some anticonvulsant like carbamazepine, antipsychotic, haloperidol, chloroquine, that is antimalarial, olanzapine, carbamazepine, antipiperol, and also some condition like hypocalcemia, hyperthyroidism, and hyperparathyroidism, cocaine use, family history, and abrupt discontinuation of the anticholinergic medication. So these are the risk factor of oculogyric crisis. Next, what are the symptoms we can tell? So onset of oculogyric crisis is acute. Sometimes it develops after weeks or months. Okay, so acute condition sometimes rarely it develops after weeks or months. How the criteria like increased blinking of the eye, neck dystonia, tongue protrusion occur, increase the blood pressure, tachycardia, dilated pupil, facial flushing, salivations, blepharospasm is abnormal contractions of eyelid muscle is a form of focal dystonia, leads to episodic closure of the eyelids and anxiety. So I'm telling the symptoms again. Onset of the oculogyric crisis is acute and sometimes it develops after weeks or months. That is, first of all, there is increased blinking of the eye. So eye is blinking. Neck dystonia occur, tongue protrusion occur, increased blood pressure, tachycardia, dilated pupil occur, facial flushing occur, salivation occur. Blepharospasm is abnormal contraction of the eyelid muscles, is a form of focal dystonia, lead to episodic closure of the eyelids and anxiety. What are the DD of oculogyric crisis? Seizure, paroxysmal tonic upgaze, and ocular tics. So DD, seizure, we can keep oculogyric crisis, paroxysmal tonic upgaze, and ocular tics. No, with loss of consciousness and post-ictal and EEG changes occur in seizure. And we will ask about the video recording and history. EEG both help in differentiation. Okay. Now, criteria for diagnosis of oculogyric crisis. There are some required criteria and some supportive criteria. So what are the required criteria of oculogyric crisis? That is tonic conjugate deviation of the eyes, minutes to hour is durations, consciousness is preserved. So remember in oculogyric crisis, what happened? There is required criteria tonic conjugate deviation of the eye. So eye is very much important. Eye involvement occur, minute to hour duration and consciousness is preserved occur. A supportive criteria is that precipitated by anxiety and discomfort, and the patient is aware of and bothered or disabled by ocular deviations associated with dystonia, associated with low dopamine state, and improved by anticholinergic drug and dopaminergic drug. So it is improved by anticholinergic drug and dopaminergic drug. Now, how can we manage oculogyric crisis? Number one, reduce the dose. If drug induce occur, we think then we reduce the dose. Anticholinergic drugs like biperidone, procyclidine with 5 minutes improve. Okay. And second line, we can give the antihistamine, that is diphenhydramine. And L-Dopa is successful in patient with Parkinsonism. So we treatment is that first reduce the level. If it is drug induced, we reduce the level of the drug. Then anticholinergic drug, that is iperidone, then procyclizine, and anti-emetic, that is diphenhydramine. Antihistamine is diphenhydramine. Remember antihistamine. Anti-emetic causes oculogyric kinesis, and antihistamine diphenhydramine is a treatment second line we use. What are the investigation we can do? EEG to make sure that it is not a seizure, MRI to exclude not structural lesion, and team we involve the ophthalmology and neurology. So ophthalmology and neurology will involve, and yellow card provide them. So we provide them the yellow card. So this is oculogyric crisis come also. Lots of time it come. 2023 it's come. Where is okay? So that is oculogyric crisis after metoclopramide discussion. Explain it was not a seizure. That is another come. Another also come. A teenager girl was admitted with an oculogyric crisis after the GP had given her metoclopramide for nausea. Explain what has happened. So what happened? Oculogyric crisis. We will be explain that. What is I already tell. That is an acute dystonic reaction of the eye, upward rolling of the eye because of the drug. Discuss that it is a no side effect of that metoclopramide. Could explain all her symptoms. Took a drug history and admitted I did not know about the interaction with her anticonvulsants. They talked about the yellow cards and offered to explain again. So we have given her yellow card when her mom came back. She asked if the GP did the right thing to give her the metoclopramide, and I was not quite sure how to answer this. I said it was a reasonable, but the GP could or should have discussed potential side effects. So this is all about oculogyric crisis communications. Thank you very much.